Right, good evening, everybody. Welcome to this Hope to Sleep webinar. My name is Tim Brown. I'm the Vice Chairman for the charity. Um, so today's topic, or webinar topic, is the new Genio implant. So it's a really interesting alternative therapy device for people with obstructive sleep apnea. So essentially, and I'm going to keep this very simple, I'm going to leave the more technical explanations to our expert speakers, but essentially sends electrical pulses to the tongue to keep the airways open through sort of a stimulation effect. So we have two expert speakers this evening. So we have Professor Vik Veer, who's a multi-award-winning ENT consultant who has recently done his first Genio implant. So he's going to be telling us a bit more about the device and also his first implantation. And then we have Ben Fear from the company behind the device. So Ben's going to be telling us about the referral process for the surgery and also like which hospitals are currently offering it. So we'll have the two presentations. There is a Q&A which we'll do afterwards. So if you have any questions, please use the Q&A function at the bottom of your screen, and we'll go through as many as possible within the time. We'll wrap up hopefully within an hour, just give you an idea as to how long this event will take place. But any questions that aren't answered, we'll do our best to do a sort of written response after the webinar. And I'm sure you can see we have Kath and Natalie here to help with the Q&A, either written responses or answering them live. That's enough from me. So with our first presentation, I will pass you over to Vik. Thank you very much.
Kath told me to introduce myself because a lot of you people don't know me. My name's Vik. I'm one of the ENT consultants at the Royal National ENT Hospital, which is near Euston, if you know the Monopoly board. I also work at Queen's Hospital in Essex, which is definitely not on the Monopoly board. And I also have a YouTube channel. So if you want to have a little bit more information about what I've said today, it's all on that YouTube channel, and I'll link to some videos at the end. But today, myself and Ben, who's a friend of mine who heads up the English version of Genio, he looks after everyone in England. We're going to be talking about this. Hopefully, you'll see me. Actually, I'm going to make sure I can see myself. Sorry, because I can't. There. So this is the implant that we're talking about. And you can see a really big close up here. So the way these things work is that it stimulates the nerves to your throat that opens up your breathing so that you don't have sleep apnea anymore. I'm pretty sure everyone in this group knows about sleep apnea, but awful lot of the time, for example, the tongue may fall back, block your breathing, and this thing excites the nerves that brings everything open, opens everything up, so you can start breathing again, so you don't keep blocking off your breathing. So I'm going to go through this in a lot more detail later on, but to start off with, I wanted to tell you a little bit about how sleep apnea is treated right at the moment. And I think a lot of people will know this already. Nearly everything goes via the GP because that's where all the money flows through the GP. And if you turn up saying, look, I think I snore, I think I've got sleep apnea, some people do an Epworth score. Most people should do the stop bang questionnaire. And if you find that online, it tells you whether or not you've got a low, medium, or high risk of sleep apnea. Anyway, you speak to your GP and you get a sleep study, which is like a little machine that sits on your chest like this, monitors your breathing at night, tells you how bad you are in terms of severity, how loud you snore, how bad your sleep is, and all those sorts of things. And then from there, assuming you have obstructive sleep apnea, the thing that most people end up with is CPAP. There are other little different types like BiPAP and all the other things, but most people call it CPAP, which is like a mask. And what that does is blows air in and inflates your lungs, stops this from blocking off your breathing. Another thing you can do, and this is more the moderate, sort of mild end of the scale, is a mandibular advancement device. That's like a gum shield that goes in your mouth and just brings your jaw forward. So it sort of does that to you. And that's great because it's pulling the tongue forward like this so you can breathe behind it. Now, some people don't really fit into those two categories and they end up with other things like there's positional devices where you know, like wives often roll over their husbands at night because they sleep like on their back. And when you roll them over to their side, they can start breathing a little bit better. So positional devices like a woody nose backpack, like something that you feel like a tortoise, you can't actually sleep on your back at all. And then there are exercises for your throat. So there are tongue exercises and throat exercises, and the idea behind these are to strengthen up and tighten up the muscles at the back of your throat so that you find it, these muscles don't keep collapsing in and blocking off your breathing. They open up your airway so you can breathe better. And it works in particular sort of populations, but it reputedly improves your snoring and sleep apnea by about 50%. So it's well worth doing. And there are other things, little devices like an INAP device, which is like the exact opposite of CPAP. It makes a suction device in your mouth and it pulls your tongue forward and therefore stops it from falling back. A TRD is a tongue retaining device. So that sort of, it's like a suction cap that pulls your tongue out of your mouth. It's not really a long-term solution, but all these things are like the first line things that we think about when someone comes in saying, I snore, I've got sleep apnea and all these things. And these are the things that we normally talk about. Um, I forgot to add weight loss there, but weight loss is one of the things as well. Um, and weight loss doesn't often cure sleep apnea, but certainly if you lost all your weight, you'd probably reduce your sleep apnea by about 30–40%. If these things don't work, including the weight loss, then in our department at least, we go into something called a drug-induced sleep endoscopy. So that's like the next stage. The drug-induced sleep endoscopy is me trying to work out what is actually going on in your throat. So we bring people in, we lie them down on a bed, we give them a touch of sedation through the arm, they fall asleep in front of us, start snoring away, then we look down the back of the throat, see why they have sleep apnea, try and figure it out. And so from there, we go, right, you've got problem A, B, and C. Here are the ways we can think about it, fixing it. And it's typically one of these. All your faces are in the way, so I'm going to move that away. So nasal surgery, tonsils, all these things, that the sort of things we do. This encompasses about sort of 41 different operations. So there's all sorts of stuff going on there. But if those aren't suitable or not right for that person, then they go to a whole new section, which is these three things. The robot is basically where a robot removes bits of your tongue from the back of your throat so your tongue doesn't keep blocking off your breathing. A Bimax procedure is where you break the bones here and around here and bring the whole face forward a little bit, thereby pulling your tongue forward. And the Inspire is the implant that we've been using for a really long time. And well, around the world, not so much in this country. And it's like a pacemaker. It sits here and stimulates the nerve and brings it forward. So you can see it gets from weight loss and a few exercises in the back of your throat down here, all the way to surgery and then the robot and breaking your bones in your face and things like that. It gets quite extreme. Now, with the Genio implant, this chip that we have here, things have changed a bit. And it could be looked at like this. You could see your GP who agrees with you that you probably have sleep apnea. You go for a sleep study to prove it. And then effectively, you have a Genio. It's as simple as that. And it has, you know, I'm nervous about this whole thing. My whole sort of experience as being a doctor is to do this whole system and get the drug-induced sleep endoscopy in the middle, work out what's going on, and be a surgeon that diagnoses the problem and then fixes it. But it sort of changed a bit with this because you can effectively go right through here. I mean, there are some assumptions that makes this a little bit more complicated. We have to assume that you've at least tried or don't want to use CPAP. You have to assume that you're not over the sort of the weight limit and you're about the right level of sleep apnea, according to what the NHS and the company want us to be. AHI, if you don't know, is the number of times that you stop breathing on average. So this would be moderate to very, very severe, but not super severe, like in the hundreds and 120s and whatnot. And also assume you don't have large tonsils, because I mean, it'd be madness to, you know, have this thing in your chest or in your neck. And if you've got big tonsils, that normally taking out tonsils normally sorts out if they're large. And often people don't realize you should take out large tonsils before you're given CPAP, but those are the national guidelines. That's for another talk. So going back to this, which you probably can't see, so I did a really close-up photo so you can see it here. And it's kind of cool when you look at it really closely. There's all these little sort of software, like a motherboard in the middle, and you'll see these sort of paddles on either side. They're quite sort of flexible. And the reason why they're two paddles on the side, you can see if you look on a side view, those sort of metal bits just here, they're two basically little sort of stimulators. And what happens is that when these things overlie a nerve, so the nerve is coming, it's called a hypoglossal nerve. The nerve comes down from your brain around here. Hypo means underneath, and then glossal means tongue. It comes up here and comes up to here like that. And the idea behind this is that it sits just about here, and these two paddles sit on top of that nerve. And so when we turn it on with our app on the phone, you turn on the machine at night, it starts stimulating these nerves and it brings your tongue forward. So I'll show you, this is me in clinic today, and I suddenly realized I have to do a presentation very quickly. And with the power of Photoshop, I've added it. So it looks roughly that sort of shape. It's up here, if you can see me, and it hits the nerve on both sides. And it's great because it touches both nerves. So your tongue moves forward like this and opens up your airway. So instead of your tongue falling back, so these are your teeth here, your tongue comes down like this is the back wall of your throat. When you're lying on your back, typically your tongue falls back and blocks your breathing if you've got obstructive sleep apnea. But this forces your tongue to move forward. You don't really feel it because what we do is we stimulate it, not so much that you can feel it, but enough that it pulls your tongue forward. So it's an interesting sensation when people first see it. And in the patient who I did the other day, a chap done in the private sector, he's like, oh, when he saw the videos of his tongue moving forward, it looked really weird to him. And the other people who've had their tongue move forward, it just feels weird when it comes forward. So I guess the question is, how does this actually work or not? And yeah, I think it does. It's been around since 2019, but it's sort of racked up, particularly in the last few years. It's been going on, particularly in Germany, I think, and perhaps France as well. And we've just caught on now in the last sort of 6 months to, 6 or 8 months, I think. And it's going well. We're doing them one by one. There are lots of trials out there, and these are the sort of the highlight trials. They're all called weird names: Blast OSA, Better Sleep, Dream Trial. And basically, the upshot of these is that some people do really well with this, an 88% improvement in your AHI. That means you're 88% less sleep apnea. I guess 88% less tired, less snoring, all those sorts of things. But if you averaged it out, it comes to about 71 to 75% reduction in your sleep apnea. So remember, AHI is a severity marker of your sleep apnea. So it's quite useful because, we expect something similar to that with CPAP. A lot of people don't realize that with CPAP, we expect an AHI of about, I think it's 11.9. When you're using the CPAP, you come down to 0.4 or something like that. But a lot of people find it hard to use it all night. And so we have to average it up for the total time you slept. So some people wear it all through the night and then take it off for the last few hours because it's waking them up. And if you add up that time from the last few hours where they weren't wearing it, then on average, even with really good people, we expect an AHI of about 11. And that's when people feel like, oh, I've really used my CPAP well. I feel really good. I'm not tired, and my blood pressure is coming down. All those sorts of things that come about because of having sleep apnea. So it's roughly that level. And if you pick really good people, like there are trials out there that shows some people get 88% improvement. So it's as good as the Inspire. The Inspire is the other implant out there. And so the results are very similar. There are differences, obviously, between the two. And if you don't know about the Inspire, I'll quickly say it again. It's a pacemaker technology, sits there with a wire that goes to the nerve on one side. And the Inspire has been around a long time. It's 2014 or so when it came out. But at the end of this year, there'll be about 200,000 of these implanted. around the world, whereas this is new technology. It's a completely new thing that's come out. This implant works, has been used in about 800, 900 people now, maybe a bit more. There is no battery with this. In the Inspire, there's a battery that sits here like a pacemaker and it powers this thing. Whereas with the Genio, there isn't a battery. So it's not, there isn't something sitting inside you powering this thing. You actually have to power this thing each night. So you make a cut right here. This gets implanted inside underneath the skin, like in those pictures you saw of me. And then each day you need to put a sticker underneath your chin like this. So you can't really wear a beard at the same time. Sticker on like this. And this is a little power thing that goes on. And so each night you put this on, it a bit like a kettle. It gets powered up through the skin. So there's no needle or anything going through the skin. It's just a sticker on the skin, and it powers this thing through the night. And as it's powering it, it pulls your tongue forward and lets it drop back again. So that's how it works. During the day, obviously, this battery won't last forever. You charge it in one of these. So it sits like this, and there's a little USB charger here, and you charge it through the day. And I think roughly it lasts 2 or 3 days, and then you have to charge it. Sometimes you need it a lot, sometimes you don't need it so much. So there is a slight difference as well, that you need 2 cuts for the Inspire, one for this area, one for this area. But for the Genio, you only need 1 here. But the good thing about that, the Genio, is that you don't have to have another operation in 10 years. For this battery with the Inspire, you need to replace it after 10 years. With this, you have to charge it each night. You can't wear a beard. You have to be very, very careful with your beard. You have to shave it right up to the bone here, but you can just about wear one if you want to have it draping over like that. Whereas with the Inspire, it's beard friendly, as it were. You make the incision and then you can grow the beard on top of it. Now, the real difference, I think, between the Inspire, the original one that we've been using for some time, over 10 years now, and the Genio, is that this chip doesn't just work on tongue. Epiglottis is near the tongue. But you know when I said where the tongue pulls back like this? This chip actually works for all different types of sleep apnea, which is why I was saying before, I was saying you do see a GP, you have a sleep study, then you can have this, because in effect, it really does sort of work everywhere. And it's interesting because, as I said before, I think about diagnosis and you've got to find what the root problem is and then you can treat it. But actually, you can be a little bit more lazy with this. You could just go, actually, I'll just put in one of these. And it normally sorts out most problems. As I said before, I don't think tonsils are a good idea and other things like that. But you don't have to do a drug-induced sleep endoscopy where I watch you sleep and see what's going on in there. You can just go straight ahead with this because it works not just on the tongue, but it also works on the side wall of your throat or the palate or other areas of your throat that can block your breathing, cause snoring and things like that. So I think that's the major difference. And the evidence for that seems to be quite good as well. I mean, it's, as I said this before, it's new technology, but the evidence looks pretty good at the moment. So that's why we're all quite excited by this. The other thing is that with this little chip, there isn't an awful lot of metal in it. And we worry about metal in the body because if you want an MRI scan, you can't have an MRI. MRI is based on big magnets. And we don't want metal to get stuck to the side wall of a MRI machine. So this is MRI compatible. You can carry on having an MRI with one of these. With the Inspire, because you've got the battery sitting in your chest, you're only allowed particular types of MRI. There's still plenty of them around, but it slightly restricts you into what you can do, what you can't do. I mean, there's a chance of you going beep in every airport if depends how sensitive the scanners are. But I think there's less of a chance with this. There's slightly more of a chance with Inspire. The other thing that this is slightly different with is that when you turn this thing on, you use your app, turn the thing on at night, this chip will start working and it will just keep going all through the night until you turn it off in the morning. You can set it so it goes on and off at different times. And, you know, if you normally sleep at 10 and wake up at 7, you can have it set in that sort of way. And you can change different things about how you breathe and all that. But it sets your rhythm of breathing. Whereas with the Inspire, because it's sitting in your chest here, it monitors your breathing and then only works when you're trying to take a breath. So there's a little sensor near the lungs. Now, because of that sensor near the lungs, and because there's 2 incisions here with the Inspire, it's less of a chance of being able to go home after having an Inspire implant, because we're worried about damage to lung and things like that. Whereas with the Genio, because it's only 1 incision, it goes in there. It's a bit of an easier operation, to be honest, than this other operation here, because you just sit it on top of the nerve. You don't have to open up the nerve and curl a bit of wire around it. You just plonk this right on top of the nerve, and then you stitch up the hole. So it's a lot quicker. It's a lot easier. And that's why it's often easier to get people home the same day. So they typically stay for about 4 to 6 hours after the operation. My last 2 patients have only needed a bit of paracetamol. I don't think they needed anything more. One person needed a little bit of help because they were worried that it was a bit stiff afterwards. And after a bit of, as it were, physio, moving their neck around, they realized it was fine. But it works very well. It's right on the tongue, right at the front here. So initially with the swelling, feels like the tongue is quite a lot bigger than before. So it can feel like, oh, it's quite swollen. But apart from that, after having this operation, which is much easier than, you know, like the MMA operation where you bring the face forward and the robot that removes part of your tongue, this is, you know, further along down the line. This is a really small operation compared to those other things we were talking about. So one question would be, look, okay, Vik, I've heard you talk. Should I actually get one of these implants or not? It's a difficult question because if you're happy on CPAP or, you know, that mandibular advancement device, the gum shield that brings your jaw forward, if you're happy on that and you're doing well, you're not tired during the day, and there's very few sort of risks and side effects and things like that, I think you should just stick to it. I'm not here trying to like capture all the people on CPAP and try and convert them into having one of these implants, because it's not a cure. It's another treatment that still requires care and attention and commitment. And it's you know, with CPAP, you have to clean it and you have to put it on each night and things like this. You still have to sort of turn it on each night, and you can change around the settings, you know, from time to time. And sometimes you can feel it, and sometimes you're worried about the battery not charging, whatever. There's all sorts of things to think about when you have an implant, because you have to take care of it and look after it. So it's not that it's completely, you know, convenient and there's no problems, you can live life completely normally. You don't have a mask on your face or in your nose. That's one difference. But if you're already happy on CPAP or mandibular advanced device, things like that are working for you, I don't think there's any real need to move across this unless you're struggling with these things, or unless you're wearing them but you're still tired. Those are the people that we think, actually, let's try and think of something else. Maybe this implant or a drug-induced sleep endoscopy or something like that might help. And I think it's really important to understand the risks, the benefits, the probabilities of this working for you or not, because although I've said roughly most people get a 71 to 75% improvement in their sleep apnea, it doesn't mean that everyone gets that. Some people do worse, some people do better. It's a probability. It's the average. Most people are in that category. But some people do less well, some people do better than that even. Like I said, some people got up to 88% improvement. So understanding probability, that most people are in the center somewhere, it's important to understand. So you do need a really careful discussion with your surgeon. Understand what the pros and cons of this one is compared to the other ones, or in fact, other operations as well. Like I said, there are 41 other operations I do for sleep apnea and snoring, all on the NHS, all for free. And so you can see your GP and get referred to anyone. If you wanted to know more about this chip, the Genio chip, there's a YouTube video. So if you haven't heard of my videos before, this might help you understand more about it, because I've only got 20 minutes here now. People who've watched my videos will know I keep jabbering on about stuff. And I've also done a head-to-head between Inspire and Genio. So yeah, you can go and get one. And I think Ben will be talking in a minute about all the different NHS centres opening up over the country. I'm calling my friends saying, look, you should try this. This is going to be really good for you. And so my friends who are doctors around the country, particularly I think Darlington are pushing ahead, and Ben will, I'm not going to steal his thunder on that. There's loads of cool centres opening up all around the country. So you don't have to come down to see me at the Royal National ENT Hospital. But if you did want to see me, at the moment, my shortest NHS waiting list is at Queen's Hospital, Romford, Essex. So you have to drive around the M25 and see me if that's where you want to go and be seen. And remember, if you live in Carlisle or in Cornwall, you can see anyone in the country. You don't have to see me, you can see anyone. You can go from Cornwall right up to Darlington, or Darlington all the way to me in central London or in Essex. So the NHS charter means that you can go anywhere and get your treatment for free wherever you'd like to go. In America, and again, I think I might be stealing Ben's thunder here, I think in the next few days it'll be FDA approved. 70 surgeons are already ready to start implanting these. So it's really exciting. It looks like the whole world is going to start taking this on, particularly if FDA approved. So thank you. Not questions now. That was a silly thing for me to write. It's up to Ben now, so I'll stop sharing and get off this screen.
Cool. Thank you so much, Vik. That was fascinating, and I think it's quite clear to see why you've got over 180,000 followers on YouTube. A real knack for explaining things very simply. So thank you. There's some really good questions coming through the Q&A, so we'll definitely get to lots of those. But before then, I'm going to pass over to Ben, who's going to talk a little bit more about the process and where it's available. That may answer some of the questions, and then after that we will come to the Q&A. So Ben, over to you.
Am I up?
You're up.
Fabulous. Thank you very much. Vik, thank you very much for running through everything so far. Kind of going to cover some of the same ground as well. OSA potentially impacts 8 million people in the UK. That's, as a comparator, it's bigger than diabetes. So it's it's highly prevalent in the population. And as Vik mentioned, AHI is the number of episodes you have per hour, and for the Genio device, it's moderate to severe OSA, so 15 plus up to 65. And that's 3.5 million people potentially in that bracket. And 80% of OSA is also undiagnosed. So you're talking nearly 3 million potentially people with moderate to severe OSA who have been undiagnosed. And again, if you look at some of the videos on Vik's YouTube channel, he kind of talks through what some of the kind of the comorbidities that can follow through having sleep apnea, certainly to the moderate to severe levels. And then again, Vik also mentioned weight, and what we've seen in the UK is a gradual increase in BMI, and it's one of the biggest indicators for obstructive sleep apnea is being overweight or obese. CPAP is absolutely the gold standard for the treatment of OSA. It has been around for a couple of decades, and it's NICE recommended, and for the vast majority of people, it is a good option. And Vik also mentioned there's mandibular advancement devices, which pull the jaw forward. There's surgery where you remove tonsils or look at the nose and just kind of open up the airways that way. From a hypoglossal nerve stimulation perspective, it's been around about 12 months in the UK. It's Vik and colleagues across the NHS have been working very hard for many years to get this here. And Kath very kindly hosted myself a couple of weeks ago, and I just think it's very important that we kind of get the information out there that this is available for the right patient, and Hope to Sleep do a fantastic job. So I really do appreciate the opportunity today. This is relatively generic. I'm sure some of you will recognize where you sit somewhere in here. There are regional variations on this, but essentially you present yourself at the GP, normally through feeling tired. Lifestyle changes are suggested. Potentially now the weight loss jab and other things from a GP perspective. Then you're sent to a respiratory specialist. You're referred by your GP, where they would do an assessment and then potentially provide you with CPAP. There are, again, as I say, regional variations here, where some patients will be almost discharged back to the GP. Here's some kit, off you go. Others, they have a more robust system in place. And also, this is also where Hope to Sleep come in and kind of provide a really useful service with supporting patients in the CPAP use. For some patients, CPAP is not tolerated, or they refuse to use it. And that's potentially where the surgical option from a Genio perspective comes in. So the respiratory teams can refer to ENT, but also GPs can, in theory, refer directly to ENT surgeons like Vik as well. The device itself, most importantly, it's safe and it works. It's a single procedure, normally 2 hours or less. I think once surgeons do more, they get quicker. Again, as Vik said, 1 night stay for some, day case for others. The MRI conditionality is quite an important factor. Another one is the device is indicated for something called complete concentric collapse. I'll probably defer to Vik on describing what complete concentric collapse is. We have the expert here, but the device is the only one that's available that is indicated for this. The bilateral stimulation as well, and there's no implanted battery, as Vik was mentioning, and the device itself is controlled with a smartphone app. The NICE guidelines, the implant procedure guidance is kind of supported from an NHS perspective, and it is CE marked as well. Again, as Vik mentioned, the thing here is AHI has to be greater than 15, and this is according to the NHS guidelines. Greater than 15, less than 65. And central apnea has to be less than 25% of the total AHI. I think that answers one of the questions that's in the Q&A section as well. So less than 25% central. Again, indicated for complete concentric collapse, and BMI below 35. Again, patients who have not tolerated or failed or refused PAP. And an inability to use PAP is actually classed in the NHS as less than 4 hours per night, less than 5 nights per week. So again, I believe there's a video where Vik talks about what happens if you don't use your CPAP for a significant amount of time during the night. So it's and there's also the unwillingness to continue to use PAP, CPAP, BiPAP, APAP. There's multiple names for it, but they're the types of patients. So what's the process? Patients, they are once you are referred by your GP or by your respiratory specialist, you are essentially evaluated for suitability for the implant. Everything from BMI, our exclusion criteria for the device, as well as other comorbidities. We obviously want to make sure that your sleep-related breathing disorder, SRBD, is relevant. There are, I think there's probably more than 100 different types of sleep-relating breathing disorders. So it's important to find the correct ones from that side of things, as well as eliminating the fact that it's central apnea as well, or mixed apnea. And then also we wait for, you have to stop your CPAP before trialing this, using this device as well. So what we then do is, again, as Vik demonstrated, is we would send out some of these patches for patients to try prior to implantation, just to make sure that they have no skin reaction to the sticky pads. It's a hypoallergenic adhesive, so patients should be fine, but we want to do a belt and braces approach to make sure that there are no kind of issues. So we have patients trialed for 5 to 7 days prior to implant. You then have the day of the implant itself, where surgeons like Vik will perform the procedure. As I say, sub 2 hours is standard, and potentially considerably less than that as well. Then once the device is implanted, it's about 2 months where we let everything bed in, let everything settle down, and then we essentially turn the device on. And then what we do, it's almost like weight training. We slowly increase the intensity of the device because what we want to do is not disrupt sleep, but cause that very gentle tongue movement forward, and as Vik was describing, opening up the airways. So there is a relationship that kind of develops once the implant's done in, where you would be seen a couple of times within the first 12 months to just fine tune and customize the device to your particular settings to optimize that airway opening, but without disrupting sleep from that side of things. So it's a commitment on both sides for this device. It's not a one and done. It's a partnership from that side of things. And that just leads me on to the team at Genio. We are a patient-focused team. It makes me feel a bit old now. We have 40+ years of experience working in the NHS as a team. We're all kind of DBS checked and clinically certified and trained on the device. And we have over 10,000 hours of operating room experience. So from a company perspective, I am biased, but I think you're in very good hands with regards to the support both before and after surgery. What I would like to do is highlight kind of where you can get a little bit more information on this. The reason being is there is actually a questionnaire on our website that if you follow it, it will take you through. You fill out the questionnaire, and then what we have is we actually have a team in the UK, and we're a European-based company. We have a team that will then get in touch. If you are potentially eligible for this device, we can then provide almost one-on-one guidance on how to be referred, where to be referred, and the potential route to being treated. Again, this is not it, for me. It's right patient, right system, right outcome. So it's about picking the right treatment for your OSA and getting in front of the experts to help guide you and kind of try and keep you as healthy as possible. But the take home for me is, please jump on the website, have a look, go through the questionnaire. That will put you eventually through to one of the team, who will be more than happy to kind of have a slightly more in-depth conversation and hopefully guide you through the nuanced way in which the NHS works. The NHS does work, but there is a waiting list. As I say, we're opening up centres both in the north, and there's already 4 centres in London in the NHS, and also there is the private sector as well. So there is a treatment option out there, and I think the take-home message is it's here. It's finally here. You have a hypoglossal nerve stimulation treatment option available on the NHS, and more hospitals are coming online on an almost weekly basis. So it's very positive news, and I appreciate your time. I think we'll hand back over to Tim.
Thank you, Ben. So finishing with a meme is always the best way to finish a presentation, I always feel. Thank you. And that's something I love, the ethos of the company, the right treatment for the right patient, and that's your number one focus. That's fantastic. We've got over 50 questions in the Q&A, so I will sift through some of them. Please jump in, interrupt, so we get through as many as we can in the next 20 minutes. Out of respect, however, I will have to start with Steve's question, who asked his question 2 minutes into the webinar. So his question is concurrent ENT disease like RRP a contraindication?
Respiratory papillomatosis. Depends if it's causing the obstructive sleep apnea or not. Because it's not actually within the airway itself, it doesn't actually interact with the mucosa of the airway, whereas RPP is, then well, RRP, then I don't think it would be. But it would really depend if these papillomatosis lesions are causing sleep apnea itself. They may have changed. Is that what you were talking about? Respiratory papillomatosis, or because I know RRP rather than RPP.
Let's say RRP.
Yeah, thank you. Yeah. Yeah, then yes, it would be, because it doesn't actually involve the mucosa, so it's not going to affect that at all.
Right. You're gonna have to help me out, guys. There's loads. How about, and apologies if I missed the answer to any of these. Is there an age limit for the Genio? There's a question around children with sleep apnea and Down syndrome who can't tolerate CPAP.
Is that Vik? May I? Is that okay?
Yeah, go for it. That's your thing.
For children with Down syndrome, the Inspire device is indicated for children with Down syndrome. We are adult only for our device. So from a right patient, right system, right outcome, that potentially would be an Inspire patient potentially. But I'm not aware of any pediatric treatments at the moment.
When you say adult, are you talking about GCSE or A level?
A level. A level.
Oh, right. They can vote.
Yeah.
But Down syndrome can have at what age?
It's an indication for Inspire, so I'm not 100% sure, but it is indicated for pediatrics.
Yeah, it's case by case, isn't it?
I think so, yeah.
There's a question which has a few thumbs up, which is the AHI number you mentioned. Is that pre-CPAP treatment or on CPAP?
Yeah, pre-CPAP.
Pre-CPAP. Great, thank you.
I'll just jump in as well, because there is a question that's been asked quite a few times about the Genio being available in Scotland.
No, not at the moment. Scotland are they're trying to separate themselves ever so slightly, and I've got a few patients from Scotland who want to get it done, but they can at the moment only get it done privately.
Okay.
We're working on it, but it's a different funding stream to the English and Northern Irish NHS. So working on it to be updated.
I think I've got a Northern Ireland patient coming down to London. But I think because you're setting up in Liverpool or something, they might just hop across the border there.
Entirely possible as well, yeah.
Are we going to say how much this is for private? Because there is a question and we've had emails about that. Is anyone going to dare to say?
It's pretty expensive because the device itself is with VAT, it's 24,000, isn't it? So with the sleep studies and all that sort of stuff and the hospital charges and stuff like that. I mean, at the moment, I haven't taken any money for the private case, but I think it's about £35,000.
Yeah.
That's if you include everything: device, surgeon, anaesthetic fees, hospital fees, appointments, things like that. So it's a hefty bill.
But as you said, the NHS are now providing it for the suitable people.
Yeah, so it's free. Yeah.
Yeah.
Is there a bulge under the chin where it fits after it's been implanted?
I mean, initially there will be because of the swelling, and in one of my cases, she's had a little bit of a bulge for about 2 or 3 weeks now, because she might have had a little bit of a clot there, but it's coming down. It often afterwards you get rid of a sort of I don't know what you'd call it, like a turkey neck or something like that, because we can't have that afterwards. So if you've got a hanging down neck, it sort of gets tightened up a bit. So it's a free neck lift. But no, yeah, it's almost the opposite. It gets a bit smaller.
Oh, right, okay. There's a few questions about the battery charger. One, what's the lifetime of the battery, and also whether it could be taken on a plane as well?
Ben, do you want to go for this one?
Yeah, absolutely. So essentially, the external battery, it's the power unit. On the NHS, if the device was damaged, it would be replaced free of charge. So essentially, there is no battery. The external power unit, if for whatever reason it was damaged, it's kind of covered on the NHS. So that it's a tricky one to answer because there is no battery. So and if
maybe they're worried about like a Tesla car, it runs out after 100,000 miles.
Right. Yeah. No.
You just get a new one, wouldn't you?
Yeah, basically. So it's difficult to answer because there isn't a battery technically.
Yeah. Yeah, you just get this replaced, and out on the NHS you get the stickers for free as well, don't you?
You do, yes. Yeah.
So it's a lifetime sort of supply.
Yeah. There's a lot of questions down that list. Natalie might be able to go and get rid of them all, because I'll ask the question if it's possible to for you to, either of you, to answer. People are saying, what centres is it available at now?
Over to me. Okay, so if we kind of start at the top and start working down. So we have centres looking to start in Newcastle, Darlington, Middlesbrough, Manchester, Leeds, Sheffield, Liverpool, Birmingham, Nottingham, and then 3 or 4 in central London, Bristol, and a couple of others that are kind of there or thereabouts. So it's
6.
It's early, but essentially there is a centre nearby for most people.
Yeah, that's a lot more than I thought.
Yeah, if there is anywhere which has an Inspire unit starting, there will probably be a Genio implant starting there as well, because the NHS England, for wherever they're going, have asked us to do both.
Oh, that's good, because the best one for each person, there will be a best one, I'm assuming, for...
Well, some people, there's a bit of a choice. And you go, well, actually, both of them would work well for you. I reckon about 50% of people get a choice.
Yeah.
So which would you like the look of? Do you want this one or do you want the Inspire? But you're right. Some people would say, look, this other one won't work for you. You're going to have this one if you want one or not. Or we can go for one of the other operations, and then we talk it through. That's why it just needs a bit of a discussion.
Yeah. That's good, though. That's such a lot of centres already on board. It's very good.
And Ben, is Sunderland not going for it? Should you want me to talk to them again?
Yes, please. Yeah. I think the thing to bear...
they've got you back.
The thing to bear in mind...
How many times I have to call them?
No. The NHS is wonderful, but sometimes it's not quick. So expression of interest versus you could have it implanted tomorrow, there is a bit of a gulf between those two things. So we are working with these centres, working with the integrated care boards, internal compliance, procurement people, also the training. You know, Vik's been on the training. You know, twice supported
2018 and
so you know the training support is vital, because the important thing is the right patients get access to this treatment and the outcomes are good. You know, as Vik was mentioning, it's not a cheap bit of kit. So the NHS wants to know that this is helping people and it's for the right people getting the right outcomes. So the NHS is wonderful, and I daily repeat this mantra, but it is a little bit slow and inefficient at times. So if there isn't a centre near you, there will be eventually. But if you go to the geniosleep.com website, we can help steer you to where they are doing these procedures. And hopefully get you in front of the right people from that side of things.
And we just need to say as well that Vik does implant both, so he's not here tonight to favour one at all. We might grab him back if we do one for that one. So this is very, unbiased tonight. It's to give information to everybody.
And on the NHS, it doesn't matter which one we do. We don't get paid differently. It may be different for maybe the American counterparts, but it doesn't matter which one we do. Or even if we just take their tonsils out, we get paid the same amount.
Yeah.
So, yeah, it's ideally we want to get people fixed so they don't keep coming back, and we can free up a space for someone else on the waiting list.
There's been a few questions about specific professions. One about HGV driver and one was a flute teacher. I'm guessing the idea is to go onto the Genio website and have a initial sort of screening discussion with your team, Ben. Would that be the right answer? Or
HGV, yeah, fine, but there is perhaps a little discussion needs to be had around flute or musical instruments, because there is a possibility, although incredibly rare, there's a possibility of damaging the nerve to your tongue. And I'm not sure, have we had any, Ben? I can't think of one, but I haven't seen much in the literature. But if we did damage the tongue and one side of the tongue didn't work very well, and they are a flute sort of, maestro, whatever they're called, then that could be the end of their career. So it's important to weigh that up against, well, I'm so tired I can't play anyway. So yeah, we've got to be careful about that sort of thing.
The safety profile of the devices are all in the kind of the clinical literature. So the serious adverse events, they do exist, but it is comparatively, it's safer than a cochlear implant, for example, from a serious adverse event perspective. So it's again, as Vik, you were saying, it's a discussion with your surgeon with regards to the risks of any surgical procedure.
It sounds like the success rate is very high, but if there is a problem or it's intolerated, can it be removed?
Well, it can be removed, but often it's quite easy to remove. It's easier to remove than the Inspire. But often we'd say to people, well, just don't turn it on. You can barely feel it anyway. Instead of opening up the wound again and pulling it out, you could just decide not to power it up, not to turn it on with the app. So it's often easier just to say, well, you don't need to. We haven't come across a person like that yet, but you can remove it. It's 4 stitches you need to remove, basically. If I may, can I share my screen and show you what I meant? Here it is. Ah, that was me. You just bring this a bit bigger. I don't see why. Okay, you see these little bits here? We stitch it in that little hole just there and there. And so we just cut those out, cut this one out, and the same on the other side, and then we pull the thing out. It's not swizzled round the nerve like the Inspire, where you have to be a bit gentle not to tear the nerve as you pull it out. It's just sitting on top of the nerve. So you just take the stitches out, and then you can pull the whole thing out. You still have to make the cut, open up the wound again. But like I said, you could just decide not to use it anymore because you can't really feel it. It's not like the Inspire where you can always feel it and you get this twiddler syndrome thing where you're constantly moving it around and stuff.
So post surgery, how is the AHI measured? Would you have another sleep study? That's for
you can have another
DVLA
sleep
notification.
You do need to wait. You can't just turn it on the first night. Same as Inspire. You wait for it to bed in for the first 1 or 2 months. And once it's all healed and the swellings come down, everyone's happy, then we turn it on in its lowest level. And then each week we turn up or each 1 or 2 weeks, we turn up the amount of intensity to the point where it stops your sleep apnea. And then you can say to us, look, I got to level 3 out of 10. And now I feel so much better. I'm going to stay on level 3 for the next 4 weeks. And if they stay feeling like, oh, I've got so much energy, I feel great, and my snoring stopped, all that sort of thing, then we do a sleep study just to prove it, because some people feel great, but they may be at 7 or 8 rather than under 5. And we say to them, well, try going up from 3 up to 4 and see how you. And if they go up to 4 and I still don't feel any problems, it's not disturbing my sleep, but my AHI has come down to less than 5 now, then we'd say, look, we're good now. We keep checking the sleep study until we know a good result, basically.
Yeah. Mm.
Questions for Ben. So in terms of the device itself, any latex or any nickel in the device?
No. Short answer is no. If there was, what we have is kind of a list of the device. It's encapsulated in silicon, so there is nothing that's in contact with the patient. But again, patient-specific conversation with your surgeon, and we do have a kind of a list of materials that the device is made out of. But short answer is it shouldn't be any issues there.
The same stuff that breast implants are made out of.
Right. Mm. Can I ask a question for Emma Cooksey? A lot of you know Emma. She'll be speaking to the USA network. She's asked, she said, I know people with low arousal threshold can struggle with Inspire. Is Genio similar to that? And also, can you explain why the Genio works even though it doesn't sense people breathing in? Does it just move the tongue forward at regular intervals? Can you remember all that?
Ben, do you want to do the first one? I'll do the second one.
Yeah. Kath, could you just remind me of the first bit of the question?
The first part was, I know people with low arousal threshold can struggle with Inspire. Is Genio similar in that respect?
Should I do both, Ben? Sorry.
Yeah, absolutely. I can answer both as well, but entirely, yeah, go for it.
No, if you're go
No. There's only
okay,
one professor
just in
on here.
case just in case people are, because Emma Cooksey is on like this sort of level. So low arousal threshold basically means that you're quite a light sleeper. So, you know, some people can sleep through a fire alarm and stuff like that, whereas some people, you know, a cat can fart 3 doors down and it wakes them up. So those sorts of people who wake up very easily often do quite badly on CPAP because it's this thing in their face and it just wakes them up and disturbs them. Now, the way I think it may be different in America, but the way we know about this problem in England, and what we do is we try and clean off the wound clean off the nerve as much as possible, because what we want is these little paddles to sit directly on the nerve, not on everything else. Now, some surgeons we know just slap it on and there's all sorts of tissue in the way. So you have to put a lot of power through here to stimulate that nerve. And when you do that, a lot of the energy sort of leaks away and starts touching other parts of your neck. And it can wake people up. Now, the way to avoid that, if you are one of these low arousal threshold people, is that you put this right on the nerve. So the nerve is there. You don't leave a chunk of tissue between the two. You put it right on the nerve, so that when it stimulates, you only have to use a stimulation of 1 or 2 rather than all the way up to 9 or 10. And what you're really doing is just gently stimulating. So it doesn't stimulate everything else around it. And that way you can stop the person from feeling a sort of tingling or a sort of electrical shock sensation. All you're doing is gently stimulating the nerve to bring the tongue forward. So there is a gap between it stimulating you and waking you up and disturbing you and irritating you, and it not doing anything. The window is much bigger. So the fact that it's moving and not causing any problems with your throat is that big window in the middle. And you can make that window bigger by sitting this right on the nerve. So I've done 2 implants in people with very low arousal threshold. And as long as you stick it right on the nerve, then they even if they put it up to 7 or 8, they don't actually feel it. They just see their tongue come right out. And so these people generally need an intensity level of 1 or 2. So the other question was what?
Just a minute, I've lost you, Emma.
You saw Emma's question about, oh God, she's got so many questions.
I've got it.
What was
No,
it?
it's the second half. Does it just move the tongue forward at regular intervals?
Oh yeah, and I saw another question by Emma. So yeah, what you do is you look at the sleep study before we put the implant in, and you go, right, this guy breathes about, say, 13, 14, 15 breaths a minute. And then what we do is we time it so it's roughly the same as what you did when you were sleeping before the with your sleep apnea. So we say, right, if you normally breathe 13 breaths a minute, we'll put you back on 13 breaths a minute. And so it starts opening up your airway 13 times an hour. Now, sometimes we don't need that much. So we put it in and you go, actually, it's sort of interfering with me. So we can turn it down to 12 times an hour, 12 times a minute, or 10 times a minute. So you can change it after it's been put in.
Yeah.
I think I also saw a question by Emma saying something about how does it fix the lateral wall? Is it? Or am I getting that wrong? Is that someone else?
I can't get rid of the questions when they're answered. Are you doing that, Tim?
Yeah, you click on answer live and then done.
Oh, right. Okay. Well, Emma's answered live on that one.
Sure.
I've seen a couple as well where they've said they've been diagnosed by our charity. Where does that leave them? Do they go to the GP? Well, when we diagnose anybody, it's usually because there's horrendous waiting lists in their area, or it's because the GP may refuse a referral. So we're trying to prove, do it. So we have already advised people who, when we've given them the sleep study, to go to your GP anyway. And I suppose that would be the time. What would happen in that case, Ben? Somebody has just been diagnosed privately. So normally they would go to the GP, and the GP would refer them to the sleep clinic. Can the person? It's a bit awkward because, like, some of the criteria is failed CPAP. Can't use CPAP. Well, they're not at that stage yet. They've been diagnosed privately. So the first time they're going to the GP for a referral, what do they do? Do they ask the GP for a referral straight to Genio?
I think it would always be, sorry, Tim, were you going to answer that?
No, I only said Ben because I thought that was, if you know the answer, that's great.
I think the idea is that everything, it won't go through Genio as a company. It would still go through to the NHS sleep centres. So the GP will refer you to your local centre. And if you said, look, I'm interested in implants, but I want to hear what they say.
Yeah.
Well, then, if you're interested in implants, I would go to an implant centre, the one closest to you, because you may say, look, I don't want CPAP, and officially that's fine for you to have a Genio, but I would recommend actually using the CPAP whilst you're waiting for your Genio, purely because if you have an operation without CPAP, there's a much higher risk of complications after your operation. The operation success rate is lower without CPAP for 3 months beforehand. There's all sorts of issues because if you imagine you're making a wound here and putting something in, if you're not on CPAP beforehand, no oxygen's getting to that area, it's not going to heal very well. But if you're on CPAP for 3 months, you're back to a normal person, basically, in terms of healing and chances of problems with having an operation. So if you can use CPAP, even if you don't want to use it so that you can have your implant operation safely. And then later we can wean you off. So we can call it a bridging therapy. I think everyone should at least be on CPAP just to protect themselves from any, because it's an operation, it's a big operation. It's an hour, 2 hours.
Yeah.
So it's something we shouldn't take lightly. Putting a CPAP on is risk-free almost. So please don't discount it just because you don't like the idea of it. You should at least try it.
Gavin Phillips. Gavin, I think he's just moved positions actually, but he's a service manager at one of the clinics. And he's saying here, I think the biggest challenge as a service manager is that the ICB funding for this treatment requires a strict selection process, as either Inspire or Genio is 10 times the cost of CPAP, considering 10 years of treatment as a comparison perspective. Value for money and NHS financial sustainability comes into question, especially as we are all taxed with demonstrating cost savings in treatment and diagnostic pathways. So can you see that as a big stumbling block?
Ben, or do you want you to?
Yeah, I was going to say Ben.
Yeah. So it's quite a long-winded answer. So bear with me here. What we are currently doing is we're currently looking at the health economic data around ISAs and QALYs with regards to what NICE considers cost-effective treatment. But if you look at NICE guidelines on this, Genio sits quite a way down the treatment pathway, in so much as patients will have not tolerated or failed CPAP. So while CPAP is the gold standard of treatment for OSA, the patients who would be eligible for hypoglossal nerve stimulation aren't using it, aren't getting the benefit from it. So therefore, CPAP is not cost effective if they're not using it. It's not helping with their OSA, and it's the potential comorbidities that come with it. So we are in the process of getting a health economic paper put together, but we are well under the NICE threshold for quality adjusted life years and ISAs. So as far as the ICBs are concerned, and certainly with the new 10-year NHS plan, treating OSA is a prevention rather than a cure for potential comorbidities down the line. So it fixes that. The fact that the device is app-based means that the patient can control it at home. So it's digital and it's out in the community as well. So as far as a 10-year plan, and from an ICB perspective, we're very comfortable that we're aligning with what the plan is from a future-looking NHS. Yes, it is expensive, but it is not available for everybody who is diagnosed with OSA. It is a specific cohort of patients that have, kind of gone through the steps. I hope that answers it without getting too geeky. Sorry about that.
Yeah, well, I think Gavin will appreciate that because, he does everything he can to help the patients. So I'm sure he'll be referring if he can.
I'm mindful we've already gone over the 1 hour. Maybe we do another 5 minutes of answering as many
Is
questions.
everybody okay for that?
I'm okay, yeah. I'm happy.
Quick fire almost, and then we'll finish the rest.
Well, I've ticked two to be asked.
You need to click on done.
Oh, well, I didn't want to do that because I haven't asked the question yet, so I'll read it then. As this reduces AHI on average of 75%, how about the other 25%? Could it be used in conjunction with the CPAP machine some nights as a dual treatment? And that would be the same, I suppose, for MAD or for any other treatment option someone's using.
Yeah, so if you used the Inspire or the Genio or any sort of treatment and it brought it down by 70%, often that's to the point where you no longer need any treatment. So, I mean, if you were 100 beforehand, you brought it down by 75, you're still in the severe bracket. And therefore, yes, CPAP would be a good idea, but it's not really eligible for people who are at 100 at the moment. So the idea is to use the implant, you get yourself down to an almost normal level, And then you could use exercises or positional devices or something like that to bring you down those last few AHI points. So it's not that you're bringing yourself down to 20 or something. We're aiming to cure you with the implant, as it were. But you're right. If we don't get to the point where you are cured or you're not completely satisfied, well, as I said, there are 41 other different operations we can do, other treatments, other therapies we can give people.
Yeah, because I wouldn't be happy with 75%. I would need something for that extra 25%. And for those of us who use CPAP, which is probably most of us on this webinar, like my diagnosis was an AHI of 32. But if I have not so good a night, or not even a night, a day, I sometimes think, oh, I didn't look what my score was. Oh, I was 10 last night. No wonder I've had a bad day. So actually 10 or 8 can really affect some people.
Yeah, but that would be your CPAP working at about 60%, right? 66%.
Yeah, I mean, that's not every night. I'm on about just occasionally,
Yeah.
So it's, but I'm just saying, if it was a regular thing and I was severe and I still was down to, I don't know, 15 and, I would still want to treat that bit that isn't being captured by the
If it's it's all about patient selection. You've got to pick the right people to do it. I mean, I wouldn't give it as a first line for most people, because I'd say, look, honestly, you could have this operation which will effectively cure you, I think, or this implant which will hopefully reduce it by 75%. And then if there's anything left over, we can try an operation. So there's all sorts of ways of looking at it. I think generally what I do is I do everything but, and then hopefully the last thing we can do is the implant, and that should just finish it off, if that makes sense.
Yeah, that does, yeah. And the question, which is definitely for you, Vik, is what about people with UARS, which is upper airway resistance syndrome, for those who aren't sure, where they've not quite got sleep apnea, but the symptoms are just as bad. Is it even approved for it? Will they even allow it?
No, it's not approved. I mean, I think my 2 hospitals are the only ones in the country who are allowed to treat upper airway resistance syndrome surgically. But it's because as we said before, it's a really expensive device. And it's not been tested on people with upper airway resistance syndrome. It's not something that the NHS is going to fund at the moment. But like I said, there are loads of different operations and treatments for upper airway resistance syndrome available. So you'll end up having one of those other ones.
Somebody's asking about laryngeal. Oh, I can't say it. I shouldn't have. Laryngospasm, because there's also the other one as well, isn't they? What they're asking is, can somebody with this have this type of implant, or is in a case like that, would it be better to go for the other implant?
This
laryngospasm.
If it was laryngospasm,
thank you for saying it correctly.
I would, if that was a problem. I mean, it doesn't affect the same nerves. These are hypoglossal nerves. It's maybe a little bit of the ansa cervicalis, but I think if you were to choose between the 2 implants, I would choose Genio if someone had a laryngospasm problem, purely because it's not the same. The Inspire collects some of the other nerves in the throat, not just the hypoglossal nerve, and therefore the Genio is very specific for both of the hypoglossal nerves. Whereas some of the nerves that can interfere with sort of clenching of your airway during laryngospasm, I would say that perhaps a Genio would be better in that case.
Well, as if you aren't busy enough, Vik, Bill's asking, can I arrange a private consultation with Professor Veer and then be funneled into the NHS?
Okay, so I wouldn't see the point in doing it that way, because even if you saw me privately and I wrote to your GP and said, dear GP, can you please refer this gentleman to see me on the NHS, which I do a lot. It's not going to allow you to skip the queue. That's against the law in this country. If you see someone privately, you still have to go through the normal process on the NHS. I guess if you did a sleep study, maybe a drug-induced sleep endoscopy, some other stuff first, you can come in at a slightly different point in the NHS. But you still have to see me as if we've just met for the first time in clinic in the NHS. Then say, oh yes, I remember you, we did this, then you can go on. But I can't say, oh, don't worry, I'll get you in next week. We're not allowed to do that. So I would save your money and just see me on the NHS.
You always say that. Don't pay me, go to the NHS. And Anne's asking ongoing costs after the operation, and can the app be hacked?
Ben, you do the app, but there are no ongoing costs.
Yes, correct. With regards to ongoing costs, none. And with regards to the app, what you're doing is the device is uniquely syncing to your implant, well, not to your implant, sorry, to your power unit. So it's a Bluetooth connection, and Bluetooth can only connect to one device. So can it be hacked? We're unaware of that being a problem. And there are safety measures built into the device that even if it was, any problems, you just take it off. That's the bit that's keeping the kind of the programming data for you. If there was any concerns whatsoever, don't put it on. It's very easy, just keep it away from your chin. So as far as I'm aware, no. But if there were any concerns that a patient had, don't put the device on, and let's bring you in and have a look.
So is there no remote monitoring function with the app?
Not currently, no. The data of usage and power settings, etc., is stored on the activation chip itself.
I've just
physically connect to it. So, okay.
I've just seen a question from my husband. John Herp is asking, is the operation under local or general anaesthetic? I hope he isn't thinking that we'll pay for it privately.
I'll hold her down. No, it's under general anaesthetic. It takes about an hour or so.
And I'll ask a further question that he hasn't asked. He already does have a pacemaker for a condition called swallow syncope. Would he be eligible?
Ben?
Short answer is not for the Genio. So they would potentially be eligible for the Inspire system. But Genio, any active implanted medical device, pacemaker, defib, spinal cord stimulator, deep brain stimulator. At the moment, as Vik said at the start, we're relatively new. We simply haven't tested all of our devices in conjunction with these. So to be safe, we just say it's a contraindication for the time being.
With Inspire, what they've said to us is that it can be done, but we're just going to try it out first. So I think that's what Genio will end up doing as well.
Yeah.
Do you think some of the sleep clinics are going to be resistant when their patients, after this webinar, suddenly start descending on the sleep clinics?
Ben, I work in two really sort of surgical centres, so it's, you know the rest of the country better than I do.
Change is slow, especially in the NHS, but change is also inevitable. So there may be some resistance, but it may be we haven't been able to educate everybody. So webinars like this are hugely helpful, but if they don't know, they don't have the information, then potentially sometimes patient power is powerful, and and getting them to educate the physicians. But we're here to help educate healthcare professionals. So if you hit a barrier, get us on the website.
Yeah, because I was more thinking of the workload as well, that suddenly, tomorrow hundreds of calls might go into the clinics. Is it just best if they direct people to you first, perhaps, to see if they are eligible before they consider putting a referral in? Would that help the clinics?
I think going to the website geniosleep.com
Yeah,
would give the patient more information.
yeah. I did put that link in the other chat, not the question and answers, the other chat. If anyone wants that link, that'll take you straight there to the questionnaire.
Yeah.
I made some questionnaires once, which I think are available. I can send you a link, which if you're on CPAP or mandibular advancing device and you're not getting the benefits you're hoping for, you can do these questionnaires as if you're wearing CPAP, and you can show your clinic, look, although I am using it 7-8 hours each night, I'm not feeling better. I'm not getting the results I want. Look at my questionnaires which show that I'm still tired, which I still have problems. I'm still waking up at night for a wee, all those sorts of things. And therefore, although it works for a lot of people, it's not really working for me. Can I at least speak to one of these other centres around the country and talk to them about it? I mean, those other centres might turn around and say no, but knowing the answer is important. I mean, they might say, yes, we can do this, this, and this. And then when you hear all the risks and complications, you might go, actually, oh, I'm okay, I'd rather not. But having that conversation is really important.
Yeah. Barbara's asking about the USA. So I think I would just keep your eye on the FDA, which you were talking, you said, Vik, very close, you know.
And said it would happen in June.
June. Right. So we're a month late, but if you keep your eye out on your side, and I think Emma as well, follow Emma Cooksey, who's here. And she'll keep everyone updated in the USA. But you could also contact Genio. I'm sure there's a link to Genio in the USA, aren't they, Ben?
Yes, there is.
Yeah.
So when you go onto the geniosleep.com website, it will ask you basically what region you're in. And if you click that, it'll take you to the respective page and language. But yeah, with regards to FDA, we do not have FDA approval as we sit here now. We're kind of 95% of the way there. We have a letter from the FDA from a pre-approval perspective. We've ticked all the boxes as far as we're aware, and it is a waiting game for us to get the stamp. But it soon, soon.
Yeah. Gavin's asking, does Genio assessment require the drug-induced sleep endoscopy assessment for suitability first, like the Inspire wants?
No, you skip that step. You don't need it.
You don't need it with this one?
No.
Why's that then, Vik?
Because it works everywhere, basically. Why do it? If it works on the side wall of your throat, if it works on your tongue, if it works in all the different areas, why bother doing it?
But the Genio's different, you mean?
So the Genio, so what I'm saying is, because the Genio works in all areas of your throat, basically, all the different parts.
I meant Inspire. I said the wrong one.
Yeah, with Inspire, you do need to do a drug-induced sleep endoscopy.
Yeah, that's to explain to the people why that is for the Inspire versus the Genio.
Yeah. So if Inspire only works on the tongue base officially.
Nice, yeah.
Whereas Genio works on the tongue, the lateral pharyngeal walls, pillars, all the different parts of your throat. And therefore, why work out what the diagnosis is? Just plop it in, basically.
Ah, right. That's interesting.
Which saddens me, because that's a bit of lull, trying to work out what's wrong with people.
Yeah, you're inquisitive.
But yeah, officially you could just, I mean, to be honest, I still do the drug-induced sleep endoscopy. And if someone came to me and said, look, I kind of want to know, and I said, well, yeah, if you really want it straight off, we'll do it, as long as you meet the eligibility criteria. But I kind of like to know what's going on. And at Queen's Hospital, if someone says that, we'll say, that's fine. But just before you have the implant, we're going to do a drug-induced sleep endoscopy just to be 100% sure it will work for you. Yeah, that's the reason.
Yeah, because I suppose that adds price onto the cost as well, doesn't it? If it isn't necessary, how much is a drug-induced sleep endoscopy to the NHS? Is it a lot of money? I've had one of those myself.
Yeah, it is a lot of money if that's all you are doing. But if you're combining it with another operation, it's an extra, I guess, 30 quid, you know, it's not worth worrying about. But if you're only having a drug-induced sleep endoscopy, which is often what I have to do,
Yeah, well, that's
then yeah, it's over £1,000. You know, it's quite expensive. Yeah.
Yeah. I had one by Professor Katesha.
Yeah.
Just before you came, I think it was, Vik.
Yeah, I took his job. Yeah, but
Yeah,
he's lovely. He
he
mentored me for years.
Yeah, he introduced me to you. I bet you don't remember.
That was a long time ago.
That was a long time ago, and he introduced you, told me you said we'd be hearing a real lot about you, and we had a conversation. You said, Kath, if ever you want to do an event in London, I'll help you and I'll find you a venue. Do you remember that? That is true.
The offer still stands.
Oh, thank you. We might take you up on that, might we, Natalie?
I think we're gonna have to. I think last question, because we're going to wrap up. I think there's been a few questions, and I think it's been touched on. But in terms of the coming off, back on with CPAP, before, after the implantation,
Just stay on it. So what I've done with my other implant patients is stay on it if you can for at least 3 months prior to the operation. The day of the operation, use it that night as well, and keep using it until we turn it on, because it's, remember, 2 months or 1 or 2 months after the operation, you still are untreated. And then you'd start off at 0 or something like that, or level 1. And you probably wouldn't notice very much, because most of these CPAPs and APAPs and things are automatic. They only give you the air that you need. So you might as well just carry on, because at least that's safer than just turning everything off. So the chap I saw this morning, he's gone to level 3. He has been using his CPAP, but at level 3, he said, look, the CPAP's not even doing anything. It's just strapped to my face all night. So he took it off and he felt just the same. So he feels good at level 3. So now he's doing it without the CPAP for the next month or so. And then in mid-August, we're going to do a sleep study just to check that he's all right. And then we can say categorically, you don't need your CPAP anymore.
Fantastic.
And this is what we love about you, Vik, because as an ENT surgeon, a lot of surgeons are just more bothered about, you know, getting in there with the surgery and fixing it, whereas you do it thinking of the patient all the time. Please stay on CPAP, which is not your field really, how you were trained. No, but he wants to do that. He's encouraging all of us to do that for our health. You know, stay on it until we know you're risk-free.
Yeah, there's no point doing, don't come off it. If you've got something that works, why on earth would you come off it?
Yeah.
Because, I mean, the life expectancy of someone with sleep apnea that's untreated is, and for men, it's 58 years in this country. It's 62 years old for a woman. You know, you've got a 30-something% chance of dying within 5 years with having untreated sleep apnea. So why put your body through that stress of, you know, being close to dying? If you've got CPAP, use it. Don't
very blunt, very
operation.
honest. Yeah. But that is the fact, we wouldn't all go to bed with a mask strapped to our face if it wasn't good for us.
Yeah, it's not worth having a stroke over.
No, and I think while people are on here, you know, this is why we do what we do, because we're talking here about serious health risks, like Vik's just pointed out. Sometimes people are given a CPAP, even by the clinic, and they're told, you'll feel better. It's not just about feeling better. And I know that Tim and Natalie are texting about me, because I can tell them they'll be saying she's rabbiting on, she's going over time. I could tell they're up to mischief. Yes, you know what I mean? But it's not just, I mean, it's an absolute bonus that most of us do feel better. But it's not just for that reason that we're using it. It's to protect our organs, isn't it? And hopefully live longer.
Yeah, sometimes it's a bit like taking blood pressure medication. It doesn't make you feel any better, but it's making you live longer. And if
You
it means
know?
you can look after your kids, your grandchildren, all that sort of stuff,
Mm,
and be healthy with it, you
mm.
don't want to spend the last 5 years of your life after a stroke. I mean, just keep going. Don't
Yeah.
be safe.
And that's why you're so passionate, and that's where we're so passionate as well at the charity, you know, because you want to, you know, people to live a lot longer and healthier life. Because some people say, a relative of mine, I'm not using CPAP, I'd rather die in my sleep. I said, actually, I've got news for you. Not all heart attacks and strokes kill. They just can leave you very, very, you know, severely handicapped, really, can't they? It's not a risk worth taking, I don't think.
And I think on that very important
Because they were talking about us, I know they were.
final note,
I'm going to look at her phone after.
I would like to say a massive thank you to both
Yes.
Vik and also to Ben for your time this evening.
Yeah.
Covered so much. We've gone over by over half an hour, and
Yeah.
there's still 44 questions in the Q&A. They were coming in faster than they could go out.
Yeah.
So a huge thank you to both of you. The recording of this webinar will be put on to YouTube as soon as we can. There'll be follow-up to the questions that unfortunately couldn't get to in time.
We'll send them. So we'll answer as many as we can, and we'll send them to Ben and Vik for the professional responses, if that's okay. Just to
Send them to me. I'll reply. I'll
thank you very
Amazing,
much.
thank you.
And if you want to send that questionnaire, Vik, you said about the sleepiness questionnaire, it's something that they could use. If you want to send that over, we'll send that in the email out, and we'll send a link to your YouTube page where you compare both devices as well. So it's been very good, and thank you, Ben, too.
I'll put it in the chat now if that helps.
Yeah, and then we'll transfer it in the email as well.
So the questionnaires get done, and you get a free answers and how to understand all the questionnaires. So there'll be a free PDF. You don't. You might get signed up to my email, so just unsubscribe straight away. But actually, no, you don't.
Your emails, Vik. We don't need to unsubscribe. They're very interested.
Oh no, that went straight to you.
We'll include it in the email when the
don't worry, we'll
recording goes
do
out.
it in the email, Vik.
In the meantime, there's the Genio website and there's Vik's YouTube channel full of helpful information.
Yeah.
So on that note, I'd like to thank everyone for their time this evening, and we look forward to seeing you soon.
Yeah.
Thank you very much.
Thank you, everybody.
Cheers. Bye-bye.
Bye.
Bye-bye.
Bye.